Good morning, everyone. It's a pleasure to be here. I'd like to take a few minutes to talk about some of the dovetailing technology with regards to anterior segment OCT and detecting angle closure. Yesterday we heard a number of talks in terms of the worldwide burden of angle closure and the differences in pathologies that affects different high-risk populations. So I'd like to talk about the use of AS-OCT in identifying this. No financial interest. We did receive some grant support with regards to some of the study material that I'll be discussing. So as we all know, primary angle closure glaucoma is of significant morbidity worldwide, and very high populous in high populous nations, this is a major problem. And although the prevalence might be lower compared to open angle glaucoma, it is significantly more visually destructive type of glaucoma. And although we're going through a paradigm shift in terms of our way of thinking about this disease currently, thus far what we can say is that a majority of people who have angle closure glaucoma have a relative pupillary block mechanism, and we think that laser iridotomy can be a definitive procedure in high-risk individuals. But as we all know, some of the problems with gonioscopy, although we all had the privilege to study this modality under Dr. Spaeth, it does have problems in the real world. It's a single observer interpretation. It's subject to variability, even amongst experienced clinicians. It can miss appositional angle closure even with poor technique, compressing the eye, and it does require trained skills. And so one has to ask that, first of all, do people even do gonioscopy? A very surprising finding, well, maybe not so surprising, but in the GAP study by Dr. Quigley and the group suggests that more than half the people who have the diagnosis of glaucoma don't have gonioscopy even documented in the chart. So is it taught? Is it taught well? Can we capture people with angle closure using gonioscopy? And even in our academy, the preferred practice pattern doesn't really emphasize some of the nuances of the technique, primarily, a dark lit condition, a thin slit beam, etc. So just in brief summary, when we talk about screening, screening is a big thing, especially in today's healthcare systems. What are important things when you talk about evaluating a screening test? And one of the most primary importance is that the total cost of finding a case should be economically balanced in relationship to the medical expenditure as a whole. So when we talk about capturing a worldwide burden of a disease, if you have something that is relegated to the skills of few trained clinicians, then clearly you have to question the abilities of gonioscopy to address this issue in high-risk populations. So then the question is, well, why don't you just laser everyone? If you talk about populations that are at risk, just do lasers on everyone. And clearly, these are populations whereby their access to care is limited. So even if there's a slight tendency towards cataract with laser iridotomy, that becomes problematic when you're addressing large populations who don't have access to care. And if you look at data from Japan, folks who have different iris anatomy, there's this different set of complications. There's a significant degree of corneal edema that can ensue in folks who have laser iridotomies in the Far East. And so that is also of concern to just laser everyone. So the question is, can technology help? I mean, Raj just gave a really great lecture on OCT. We started talking about yesterday with Camilla's talk. And there are a number of different ways to image the angle. The Scheimpflug method-based approaches doesn't really fully image the angle. There's high-frequency UBM, which can be very, very helpful. However, it does have some limitations. You've got to have the patient supine. It takes a skilled practitioner or technician to administer the exam. It's not very pleasant when you talk about screening lots and lots of people, to have everyone come in. Again, it has the same limitations gonioscopy might have, whereby it takes a few skilled people to perform this test. And that brings up the idea of OCT, which uses a light source, as Raj just introduced. And this is a high scanning resolution with anterior segment OCT. It's a non-contact approach. The promise is that you can teach untrained personnel and can be performed in total darkness. The appeal is certainly that it's objective, provides objective numbers, objective data, and it can be reproducible, which has been demonstrated in a number of studies. Two primary modalities with regards to AS-OCT include the Cirrus and the Visante. The Cirrus is SD OCT with lower wavelengths with less penetration to the angle structure, and the Visante that has a higher wavelength with deeper penetration. Camilla and Raj had mentioned the swept source OCT, and this is an exciting new technology that's in prototypical phases, but as you can see here, higher wavelengths, incredible acquisition speeds that allow for 3D analysis of the angle view, and you just saw some high PAS in a 3D view. So how does AS-OCT compare to gonioscopy? When we look at the agreement between gonioscopy and AS-OCT, the sensitivity is fairly high under dark light conditions. And of course, that goes down when you do the AS-OCT in light conditions. But the specificity is a little lower, and the basis for that is that you're using different lighting, different landmarks. On the OCT in its current iterations, the anterior limitations of the trabecular meshwork can be harder to identify. Identifying the scleral spur can be a problem, as I'll get into. And then, of course, the flip side is the distortion that can occur with gonioscopy. So one of the studies that we were able to undertake with the help of Camilla and Cindy, who is a medical student, amongst some of the other faculty here, was to compare the performance of gonioscopy with Visante and Cirrus OCT in detecting angle closure. And to first of all identify, are these imaging modalities interchangeable, and then also look at our agreement in gonioscopy. I actually was very surprised to not find a huge number of studies over the years in Medline and Ovid in terms of just do we agree as gonioscopists. And so this was a cross-sectional observational study. We took one eye of 50 patients. They'd never had prior miotic use, no prior surgery, recruited. And basically, they underwent gonioscopy by 3 different examiners using the Spaeth classification. And were asked to sort of qualitatively grade the angle. No specific instructions were given to the observers, but we asked them, is it high risk, medium risk, or low risk? And this was a standardized lighting, but the beam width was not standardized. We really just wanted to emulate sort of when you're in the trenches, real-world gonioscopy conditions. You see a patient, put a gonioprism on, and then determine their risk to help determine what you're going to do about this individual. And the same eye was imaged with Visante and Cirrus in light and dark conditions, and the imaging was then graded by a single examiner who was mastered the gonioscopy findings. Now here, we had to establish specific criteria for what was defined as closure, so they had to identify the scleral spur. So any contact between peripheral iris and any part of the angle anterior to the scleral spur was identified as closure. Here you can see just an overview of the demographics, sort of the pathology range, the spectrum here. And what was interesting to find was that amongst the various components of the anterior chamber grading, there was substantial to almost perfect agreement in insertion, angle, and then the qualitative assessment of risk. Is this person at high risk, medium risk, or low risk? It was almost perfect amongst the 3 observers. When we look at the AS-OCT findings, the imaging modalities of Cirrus and Visante both had substantial agreement with each other. But when we compare the imaging to gonioscopy, using gonioscopy as a standard, this reduced into the fair to moderate range. And what were some of the reasons for that? Well, there was a fair number of images in both the Cirrus and Visante in its current iterations that we were not able to determine the location of the scleral spur, and so that was going to limit its sensitivity. And here we can see just at another format that the sensitivity decreased using gonioscopy as a gold standard, and there was a high number of indeterminates with the AS-OCT. So this is just this example. In the OCT definition of a scleral spur, which really hasn't been codified, but people just arbitrarily have sort of assigned that the inner protrusion of the inner sclera is thought to be the landmark on the OCT, anterior to which is the trabecular meshwork structures. Here you can see them fairly clearly delineated. But then here's an example of an AS-OCT where it's a little bit challenging to identify where the scleral spur is. And then here's the Visante, where you can see a number of the parameters that we talk about in a lot of the angle closure studies have been identified, and you can see the scleral spur there. So just in summary of the results, gonioscopy demonstrated substantial agreement. There was a substantial agreement in terms of determination of a qualitative determination of angle closure risk, and the imaging agreed with each other, but only fair agreement with gonioscopy. Now, some of the limitations, it's always hard to apply these findings to real world. The gonio was performed by 3 experienced, fellowship-trained glaucoma specialists. Again, this might not approximate what's happening in the real world when people see someone with a narrow angle, put a gonioprism on there. What's their skill set in terms of identifying who's at risk and who's not. Secondly, we used a pretty strict definition of angle closure with the AS-OCT, identifying the scleral spur. And in studies by Sakata and Friedman's group, if you ask people to just forget about the scleral spur and just qualitatively look at the image and say, is it at risk of closure or not, then you can increase your sensitivities in its current iteration. So there are a lot of variability in the studies with regards to the agreement between AS-OCT and gonioscopy. Many studies, as I alluded to, don't include the images that cannot be used, but when you're talking about using these devices in large populations for screening, you have to at least take that into account. Again, identification of the scleral spur can be a problem. Specifically at the vertical meridians, it's thought that the eyelids are cause for distortion. There's reflective structures nearby, like the iris, et cetera, that might pose a problem. But again, this is the promise of technology. I mean, we've seen sort of the trend in Raj's talk. We saw the trend that's maybe upcoming in the future with swept source OCT. One can only speculate that enhanced resolution will help to this. The sensitivities can only increase. And furthermore, AS-OCT is helping contribute to the understanding of this disease. As I said before, even though we've talked about this for years and years and years and read about this for years and years and years, I don't think people still have a true handle in terms of the primary angle closure suspects who go on to actually develop primary angle closure glaucoma and glaucomatous optic neuropathy, who are really the people that need laser iridotomies, and who of the folks who have primary angle closure actually go on to develop glaucomatous optic neuropathy. So AS-OCT and its dynamic abilities to assess the angle, I think, will help elucidate some of the mechanisms for this. And then certainly the promise of teleophthalmology. If this technology can develop to a point where an untrained or a marginally trained personnel can perform this to thousands of people who are at risk, then we're really talking about capturing this disease burden. So a number of global implications. With that, I'd like to end, but I'd also like to dovetail and just take a pause and say a heartfelt thank you for all the mentors along the way, and to Dr. Spaeth, who really nurtures the sense of community here. So, and then I'll end.